Hey guys, sorry. I had a glitch. I had to start over again. Anyway, this is the first thing. You don't know that. This is the first time you're hearing it. So this is a recording of the knee and femur lecture, and I always include a Winter Wonderland themed picture because it's always timely. And considering we just had a snowstorm last week, I think we're going to leave it up. Isn't the snow pretty when you don't have to drive through it? Yeah, it sure is. Okay, moving on. We're going to follow our standard format here for procedures lectures. We're going to go through the anatomy diagrams. Then we're going to talk about procedural considerations for the knee, talk about radiation safety protection practices, not just shields, but appropriate collimation and appropriate fields of view for radiographic exams of the knee. We will discuss proper positioning aids, and then I'm gonna detail, after we go through those general things, I'm gonna detail positioning instructions for several views of both the knee and the femur. And I think I've got an objective slide or a section on the femur with its own objectives coming up later in the PowerPoint. All right, so starting with the anatomy at the proximal femur. We're going to see tibial plateaus and intercondylar eminence, which kind of looks like a king's crown, and you would address a king as your eminence, so it is self-memorable. The lateral and medial condyles are the rounded edges of the tibial plateau, and then out front anteriorly we have a tibial tuberosity. That is the point of attachment for the quadriceps tendon. So that's the proximal tibia anatomy. Proximal fibula is really a head, a neck, a head, a neck, and an apex. The neck isn't labeled here, but it's basically after the head tapers down at the diaphysis. The first point where it tapers to the diaphysis is the neck of the fibula, and the entire diaphysis of the fibula is actually prone to fracture because it's so much thinner than the tibia, and the fibula is not meant to bear weight. So the head and the apex of the fibula form a joint, the proximal tibiofibular joint, but it's not, the fibula does not articulate with the femur. So to speak, it articulates with the proximal tibia. So, the lateral malleolus is the most common place to fracture your fibula, as we covered in the ankle last week. The other most common place is the entire diaphysis of the fibula. Very hard to fracture the head or the apex of the fibula. It's usually either the lateral malleolus or the diaphysis. All right, going into the femur anatomy now. They're calling this the femoral tibial joint. Most people just call it the knee joint, but technically it is the femoral tibial joint. Now, that's typically what you think of as the knee joint space, but the patellofemoral joint is in a shared capsule with the femoral tibial joint. So we actually have three joints in the region of the knee: the proximal tibial fibular, the femoral tibial, which is what people usually think of when you say the knee joint, and then the patellofemoral joint, which is behind the patella but in front of the femur. So there's a little fluid space in between them, and and that is the same compartment as the fluid space for the knee proper. Okay, it is a synovial diarthrotic ganglimus or hinge type joint, so that your knee is supposed to flex and extend. If your knee is exhibiting other motions, that is a injury. You need to get that checked out before you try to stand on it. So, and we'll get into some of that as we discuss more anatomy. Okay, like this stuff. So there are very important soft tissue structures around the knee, the two menisci, lateral compartment and medial compartment. Those are like fibrous pillows that provide cushion as the femur is pressing down on the top of the tibia. So you got a little bit of shock absorption in your knee. It doesn't feel good to absorb a shock in the knee, but the menisci are supposed to be there to provide some cushion from grinding your femur into the top of your tibia. For stability, the knee has 4 collateral ligaments, or cruciate ligaments, depending on the location. So the collateral, that would be 2 lateral ligaments. There is the medial collateral ligament, which is also called the tibial collateral ligament because it tethers the femoral epicondyle to the tibia. And then the lateral collateral ligament is also called the fibular collateral ligament, and that tethers the lateral femoral epicondyle to the fibular head and apex. Okay, and then for stability in the middle of the knee as we're twisting, like changing direction, and so we put a torque on our knee. And like, even though it's supposed to flex and extend, we sometimes put a corkscrew torque down the femur through the knee, and the knee does twist a little bit, one bone past the other one. But the cruciate ligaments are there to prevent it from twisting too much. But there is a little bit of wiggle where your femur can twist past your tibia. If it goes too far, the anterior or posterior cruciate ligaments could tear. Typically, your ACL is the most common, in addition to your MCL. Both of those tear fairly readily and usually from the same the same root cause. The root cause that tears ACLs and MCLs is a large external force being applied to the lateral side of the knee. The knee is meant to flex and extend anteriorly and posteriorly. It is not meant to flex and extend side to side. And so you end up stretching those ligaments, and you can either sprain them or pull them completely off of their tethering attachments. Okay. On the posterior knee, you're going to find on the posterior knee, you're going to find the posterior cruciate ligament is in the back. The anterior cruciate ligament is tucked to the front. Again, there's medial and lateral meniscus, and again, you can see the collateral ligaments. They're just reversed. So just be aware of this diagram. If you don't see a kneecap, that's because you're looking at the posterior of the knee, not the anterior. And so in the middle, the posterior cruciate tendon is on top of the anterior from a posterior view. Of course it is. That's why we call it posterior. It's posterior to the anterior one. So it's very much like dip and pip, except it's posterior and anterior. It's to discriminate. It's to be able to choose from and distinguish one of the cruciate ligaments from the other ones. Okay. So here we have the patella. The patella is the largest sesamoid bone in the body. It is upside down like the scapula, so the apex is actually the most distal anatomy. The base is the most proximal anatomy, and it is entirely enveloped in the quadriceps tendon. So, and you don't get a patella until you're about somewhere between 3 and 5 years old. Babies do not have patellas, so stop looking for those on those infant knee radiographs. All right, your distal femur from the posterior aspect, where we can point out more structures, It has two rounded articular surfaces. Those are called the condyles. And then it has two bumps just above the rounded surfaces. Those are the epicondyles. So very much like the distal humerus in the upper extremity. On the posterior side of the femur, just above the epicondyles, is a flat, before it tapers into diaphysis, there's actually a flat region where major blood vessels travel, major nerves travel through there, and you can find at least one bursa capsule, maybe a left and a right bursa capsule, as a fluid reservoir for the synovial space that is the knee joint. So bursa is a side pocket that acts as like a ballast tank full of synovial fluid in case there is aggravation, because the knee is kind of flimsy. I don't know if you noticed. And so if you aggravate your knee, the bursa can be squeezed out by the hamstring muscle and can add more fluid. Now, typically every time you bend your knee, this bursa empties out because it expands and contracts regularly with hamstring constriction. So when your hamstring is tight, the bursa is squeezing out. So that would be when your knee is flexed. But when your knee is straight, the hamstring relaxes a little bit and the bursa refills by an imbalance of pressure between it and the synovial space. So all of this region is described as the popliteal region. So lots of important stuff. You'll never see a posterior approach knee surgery because of all the important things that are traveling through the popliteal region. Major blood vessels, major nerves, and reserve fluid bursa. All of that stuff, very important structures, all of that stuff in the neighborhood of that flat surface called the popliteal surface. The adductor tubercle is an extra bony prominence on the medial epicondyle. So the medial epicondyle is like the bump that you can feel on, like go on either side of your kneecap at the very top of your knee, and you can kind of feel a little ridge right there. Those are the epicondyles. You might notice that the medial one is just a little bit more proud, a little bit more easy to palpate. That's because of the abductor tubercle or adductor tubercle that is on the medial epicondyle. So your medial epicondyle is always slightly larger than your lateral epicondyle, regardless of which patient you're dealing with. All right. Your intercondylar fossa, the part that I didn't mention yet, is a gap, basically. It looks, when the knee is flexed, it looks like a tunnel on the radiograph. That's why I mentioned tunnel views just a little bit ago. There's tunnel views and there's patella sunrise views. We'll talk about those in addition to the standard views for the knee. But the intercondylar fossa is the home of the cruciate ligaments. You need that space open so that the cruciate ligaments can tether the distal femur to the tibia at the center of the knee joint. So the cruciate ligaments are just there to provide stability and prevent the sway with rotational torque. There's a sway of the femoral condyles rotating rather than flexing and extending, rotating past the tibial plateau. The cruciate ligaments are meant to suppress that rotational motion so you get a straight flexion and extension. All right, that was the anatomy review. Let's get into how do we do radiographs of the knee. All right, in general, you are going to want to prep your patient. This typically means the pants are coming off. Make sure you clarify. I speak from experience, just listen very carefully. Make sure you clarify to your patient that their underwear can stay on, okay? In fact, in general, from here on up, going into the pelvis and through the femurs and such, we're going to want the pants on, but there is no reason for the patients to take their underwear off. Okay, so encourage them to, hopefully they're wearing underwear. That's another problem. But encourage them and specifically mention that they can leave their underwear on. You will thank me for coaching yourself in that specific script. Okay. There's a lot of people that are just way too friendly and way too open with private things. Okay. General patient position. Typically for your knee, unless it's trauma, you're going to be doing an upright examination of the knee. I'm going to try to show you both methods of knee radiography. I'm going to show you laying down and standing up. Okay. IR collimated field size depends upon the projection, but typically you can go down to a 10 by 12. Very much like the shoulder, the knee and the shoulder are roughly the same size, so a 10 by 12 cassette, typically portrait. SID is always 40 inches. ID markers will matter because there is a distinct difference between a patient's left knee and a patient's right knee. Radiation protection, the knee anatomy is nowhere near the reproductive organs. A nice little half shield can also prevent excessive radiation dose to the femoral bone marrow just outside the radiographic field. So please shield your patients. And then patient instructions. We're not going to get breath motion down at the knee, but we are going to have them hold still for us. So no real breath instructions, just have them hold the body part still if they're able to. Right, removing artifacts. Now, I haven't investigated fully, but as far as I know, you can't get your knee pierced, like at the tattoo parlor or something like that. Anatomy of interest: shoes, socks, or hose. Yes, if they have pantyhose on, or if they have pants on, those are going to show up on the x-ray when you try to take a knee. No, you cannot roll the pant leg up over the knee. You get a big bunching of fabric immediately above the knee, and it produces a hugely distracting artifact and takes away from the diagnostic efficacy of the study. Okay. All right, provide your patient with a gown, okay, front and back for those that are a little bit more modest. Okay. Your ambulatory patients, some protocols will allow for a laying down exam, but typically you're going to be doing standing exams of the knee. Okay. If your patient has just suffered an acute trauma to the knee, see ACL tears, previously mentioned in the structure portion of the lecture, they're not going to be able to bear weight on the knee. They're not going to be able to flex the knee. The other thing that's a common injury is a transverse patellar fracture, and also you wouldn't be able to stand the patient up, and you won't be able to flex the knee. So some of the positions require partial flexion of the joint to open the joint space, but that instruction goes out the window if there's any trauma, an acute injury, patient coming from the ER with a knee x-ray. Typically you don't flex the knee quite as aggressively, if at all. All right, your collimated field textbook provides guidelines. Well, your guidelines are 10 by 12, according to Mr. Tolson. Okay, there's no excuse for, we're not shooting femurs here, we're shooting knees. So 10 by 12 collimated field is plenty of field size to capture anybody's knee. Now, if you're doing bilateral standing, you're going to switch to a 14 by 17 field of view, transverse wise, okay, or crosswise, and have them stand with their feet shoulder width apart, toes pointed forward, and then center. You'll have to manual technique it because you have to actually center to the raw primary beam in between the patient's knees. ID markers, right or left side markers, must be included. Other required ID markers must be in the blocker or elsewhere on the final image. Avoid using digital annotation to place side markers on images. Okay, pretty straightforward. The number one mistake that leads to a wrong side surgery is an improperly marked radiograph. So please, please, please be setting the habit to use the correct side marker and use those consistently. Your patient will have a safer hospital stay because of that. Okay. Shield your patients of reproductive age. No reason not to shield everybody. Close collimation. If you're doing an individual knee radiograph, you do not need a 14 by 17 field. You can get it on a 10 by 12 collimation. Okay, and then optimal technique factors. Obviously, we want enough penetration power. You're going to be looking at, for sena cavitis, you're going to be looking at about 70 kVp, similar to what you would see for shoulder. And then we also have the country ham rule. Now, I know that there's some people that don't eat pork, but at the Kroger, there is a ham. It's called a country ham. It's been salt cured rather than smoked. And when you salt cure a ham, it kind of dehydrates a little bit. And so it ends up being somewhere between about 6 and 8 inches around, which is roughly the size of an adult knee. And that's why I call grid use the country ham rule, because when the body part is about 6 to 8 inches thick, then it starts generating enough scatter that including a grid might be warranted. Okay, now that was guidance for screen film technology right there. The modern digital receptors actually have grid, smart grid cleanup software where we can do larger and larger body parts without any grid at all if we apply the virtual grid cleanup software, which I'll talk to you about in digital imaging. But the rule passed down from screen film technology when grids were developed is when is enough scatter being generated that a grid could actually improve image quality, and the answer is when the body part gets to be about somewhere between 6 and 8 inches thick. So are all the knees that you x-ray going to be 6 to 8 inches thick? No, but most of the adult ones are. And so it's not going to hurt to utilize a gridded cassette. Do your knee radiograph. You could do knee radiographs tabletop if it's pediatric, but if it's an adult knee trauma, you're laying them down, transfer them over and use the table bucky. The grid the oscillating grid included in the table bucky is going to dramatically improve the quality of your image. All right, patient instructions. The patient, you got to, again, we want to model the posture if we can. If they're laying down, kind of hard. If you are torquing and manipulating, always grab on both sides of the joint or support on both sides of the joint. So mid shaft of the femur or cupping underneath at the hamstring and cupping underneath at the calf muscle to move the entire leg all in one motion. You don't want to torque just the tibia at the calf muscle and not have the femur also, externally or internally rotate and follow. Okay, if the patient does have a ligament tear and you apply rotational motion to only the tibia, you are exacerbating that ligament tear. Just know that. So be careful with that. We do not need to hold the breath. The abdomen does move, and the abdomen, in the breathing cycle, the motion of the abdomen does affect the hip and pelvis, but not even the femur do we have a breath hold for the femur. So definitely not the knee. They can just hold still. Okay. All right, here we go. Essential projections of the knee: AP, lateral medial, medial lateral, AP weight bearing, and then your obliques. The weight bearing knee is a special scenario where you're shooting it with the patient standing with their back against the vertical Bucky tray image receptor device. All right, let's get into, I think, an AP knee here. Yeah, so our AP knee, patient's going to be supine. We're going to center to 1/2 inch below the patellar apex. So we'll palpate for the bottom of the patella, and hopefully the patient doesn't have excess adipose tissue. And so once we locate that, you can go 1/2 inch inferior to that, and that will be passing right through the knee joint. Let's extend the knee fully if the patient is able to, and then let's roll the ankle so the toes are pointing straight up and down. As you're rolling the ankle, make sure you're also rolling the femur so it stays in the same motion. Okay, you can check that you're in true AP because the femoral epicondyles will be running parallel to the image receptor. Okay, well, I need to fix that slide. Parallel to what? Parallel is a relationship. All right, if you're doing a, hey look, it's Trace. If you're doing a supine AP knee, you have to account for the patient's backside, because patient with a more generous backside, their femurs run downhill more than a asthenic patient or a patient that suffers from no acetol. Okay, and so we call this the badonkadonk rule in honor of Trace Atkins and his wonderful song. And so someone send a link to Ali, the honky tonk badonkadonk song, so that Ali knows what the rest of us are giggling about right now. Thanks for that, Haley. I appreciate you sending him that. So for a asthenic knee, it recommends 5 degrees cauded. I've never seen anyone ever shoot an AP knee with a caudal angle. So typically it's more one of the lower, it's either the middle option or the bottom option. So either straight down or a 3 to 5 degree cephalad angle if they have a generous backside. Okay, and so those measurements, those are actually registry questions. So 19 to 24 centimeters, that's like average habitus, okay, or average girth, I guess. As the girth of the backside, and then, now this is the ASIS to tabletop distance that we're measuring here. Now, you have to know that greater than 24 centimeters is the threshold for the difference between a perpendicular and a 5 degree cephalad AP knee. Okay. You also have to know that it is very, very awkward to use calipers. If you can find calipers, it's very awkward to use calipers to measure the thickness of a patient's rear end when you're not even x-raying the patient's pelvis, you're x-raying the patient's knee. And so questions will be raised. The patient will be confused and curious and possibly offended. So if you are going to do this, which I've never done, I've just kind of eyeballed it or measured or, guessed. If you are going to measure it, maybe make sure you explain yourself as fully as possible, but maybe don't mention Trace Atkins. Okay. So our collimated field, obviously, we can get down to a 10 by 12 collimated field. The entire, the patella, the distal femur from the epicondyle, just, as it tapers. You don't really have to get the diaphysis, but you can see that it's tapering to the diaphysis. So we can see the epicondyles, the condyles, obviously. We can see the patella superimposed over the distal femur. Looks like the condyles are symmetric, looks like the joint space is open. We can see the intercondylar eminence, but not necessarily the tunnel. There is a slight overlap of the fibular head on the lateral tibia. Okay. For a lateral projection, this picture is actually wrong. You need to bring the affected leg forward, not like this. This is the X-ray of a lazy technologist. Okay. A proper lateral recumbent posture involves sweeping the unaffected leg forward of the affected leg. Okay. And now, habitus, regardless, this is not the lateral is always angled 5 to 7 degrees cephalad, regardless of the Badonkodonk rule. So the Badonkodonk is a variable tube angle applied to an AP supine knee. The lateral supine knee always, and the lateral standing knee, always has a 5 to 7 degree cephalad angle. Okay. You're going to want to flex the knee 90 degrees. You're going to want to palpate for the femoral epicondyle, the medial one, and center to a point about 1 inch inferior to the femoral epicondyle. Okay. If there's a patella fracture or a suspicion of a patella fracture, you should not be flexing the knee. Okay. But for a routine knee projection, the knee should be flexed about 20 to 30 degrees. That relaxes all the supportive muscles. And there are some major muscle groups. The largest muscle group in the body pulls on the knee. So the quadriceps muscles and the hamstrings tend to relax most at about 20 to 30 degrees of flexion. Okay? If we're suspicious for patellar fracture, then we're not going to flex the knee. We're just going to shoot it. We're probably going to shoot cross table lateral. Okay. For lateral knee, the femoral epicondyles should be perpendicular to the IR, and on the radiograph, the condyles should be exactly superimposed. Okay, and that's actually part of the analysis we're going to take a look at. First, we're going to be able to determine. Remember the posterior ribs for lateral chest X-ray and how one set looked magnified, and then we knew that that was the right posterior ribs? Well, the condyles are the same way for a lateral recumbent. The medial condyle is naturally bigger than the lateral condyle, but it's also magnified slightly because we're shooting a medial lateral projection. That is, where the central ray is entering the medial side and exiting the lateral side. So the medial side is got greater OID, and we know that that leads to some magnification. So the medial condyle on a lateral knee radiograph is always going to be the larger condyle that you see. And from there, we can tell whether we're rotated anteriorly or posteriorly, or if we have the proper tube angle. And so there's two signs for the alignments of those condylar surfaces. Okay, the two signs, they're related, is alignment of the inferior surface of the condyles. As we can see, that's the radiograph on the left is a perfect lateral knee. The radiograph on the right is a rotated lateral knee. Okay, and so the malposition, it's either rotation and malposition, or it's faulty tube angle. Okay, in the case of the radiograph on the right, it's rotation malposition. You can clearly say that the one that's posterior, the condyle structure, the posterior surface of the condylar structure, The one that's most posterior is also the magnified one. It's also the bigger one. So the medial condyle is posterior to the lateral condyle. So that should tell you what is it. You should need to rotate this part and shoot it again, such that the medial condyle, which is elevated, rolls forward or rolls anteriorly. So if the patient's laying with their knee on their side, you have to roll them so that their patella starts leaning in towards the table a little bit more. And then you'll get a better knee radiograph than what's shown on the right side. As far as image quality goes, you really shouldn't turn in, of the two radiographs, turn in the left all day, and thank you for taking such a beautiful looking radiograph. Maybe delete the right one as soon as you see it, because that's how bad it is. It really is. You shouldn't be turning that one in, not even if you're desperate. Okay, for lateral weight bearing, the tricky thing here is you got a manual technique. Also, it's usually with, I can't believe they didn't pick up on this. Usually on bilateral studies, you mark both left and right, so there's absolutely no confusion as to which is which. Okay. Yeah, I'm not sure how someone would think that the patient had two left knees, but anyway, always mark both sides on bilateral. It's just the thing that techs do. There's no kill like overkill. Okay, might notice that your collimated central ray is actually between the two knees, but that's okay. It's at the patient's, it's the intersection of the mid-sagittal plane and the inferior apex of both patellas. Okay, now that implies that the patient's knees are roughly at the same height and both patellar apexes are in the same horizontal plane. Your results may vary. There are plenty of people walking around with one leg longer or shorter than the other one. Okay. Now, in order to get a proper knee that does show pathologic change, that's the whole point of the weight bearing. They have to evenly distribute their weight on both feet. And so a lot of times you'll see somebody with a bad knee will lean onto the good knee and favor putting most of their weight on the good knee rather than the bad knee. And so you got to watch for that. Watch for their posture and gait as you're positioning them, and get them squared up such that they're providing equal amount of weight to both knees. All right, and this is the resultant radiograph. Femur, patella, joint space, tibia, fibula, pretty straightforward. They're looking at compartmental compression, so the knee joint technically has a medial and a lateral compartment, and those age differently. Typically, your medial compartments break down and go into degenerative joint disease and arthritic change more so than the lateral compartment of the knee. All right, doing obliques of the knee, it's going to be 45 degrees of rotation with the patient supine. And yes, the Banach rule is back. So the patient's butt didn't go away just because you rolled their leg 45 degrees. Their butt's still there, the femur is still running downhill. And so the joint space is running toward the feet. And so you need a 5-degree tube angle, okay? So, and that's typically what is shot is either a straight perpendicular or a 5-degree cephalad angle for excessive backside. Okay. With your oblique projection, it's 45 degrees externally rotated, and for the other one, internally rotated. If your patient is geriatric and needs help rotating, you can actually perform the rotation at the pelvis, and that will translate over to rotation to the opposite side leg. So raise the unaffected hip for an external rotation of the pelvis. Put a 45-degree angle sponge under there, and the downside contralateral leg will fall naturally into a 45-degree external rotation. Now, that being said, this is the position for an oblique knee. In a trauma scenario, you really shouldn't be manipulating the part. You should invoke a transverse tube angle to an AP projection of the knee. You should just invoke your own 45-degree or 40-degree tube angle rather than torquing on a freshly injured knee. All right, switching over to the medial oblique knee, you're actually going to elevate the affected side this time. So put an angle sponge under the affected hip, and then support the femur and support the calf muscle, and gently roll the patient's leg, the entire leg, internally 45 degrees. Try to keep the limb extended if the patient's able, and again, the Badonka-Donk rule applies. Okay, there it is, Badonka-Donk rule. Remember, greater than 24 centimeters, we want 5 degrees cephalad angle. That's a quiz question and a registry question. Not between 19 and 24 centimeters, we shoot that perpendicular, and then the one you never see is less than 19 centimeters. Okay, so here's radiographs of your oblique knee. I've pointed out these parts before. The oblique knees are for opening up and elongating the compartments, the medial and lateral compartments. So when you do a external rotation, you get a nice unobstructed view of the medial compartment, slightly elongated, and when you do an internal rotation, you get an unobstructed view of the lateral compartment, slightly elongated and free of superimposition. And you also get an open proximal tibial-fibular joint on the medial rotation or the internal rotation oblique. Okay, and you can see that there on the right-hand side radiograph. That is, look at that nice open joint space between the head of the fibula and the lateral tibial condyle. Okay. Our tunnel views, we have 3 major tunnel views, and then an adaptation of the Baclair method for a standing knee exam. It's called ski jumper's position. It's not in the textbook, but I can teach it to you in the positioning lab. So we're also going to learn Holmblad, which is top left. That involves a 70 degree femoral angle to the image receptor, and then a vertical central ray directed posteriorly to the popliteal region, or actually, where do you center the central ray is centered to the 1 inch superior to the condyles of the femur. For a Camp Coventry method, which is bottom left here, we're going to leave the femur alone, put the patient prone, and raise the tibia up to either a 40 or a 50 degree angle. Okay, the tube angle is going to match the body part angle. So if we flex the knee 40 degrees, the tube is going to be angled 40 degrees cauded. Okay, and the range that we can flex is anywhere between 40 and 50 degrees. So if we flex 50 degrees, we angle 50 degrees. If we flex 40 degrees, we angle 40 degrees. And then finally, over on the right-hand side, the Baclair. The Baclair kind of went away. It seems to make more sense in the era of digital technology. Okay. All right, so our tunnel views, what do they reveal? The tunnel view reveals the tunnel, also known as the intercondylar fossa. Now notice you can't see the cruciate ligaments in there. You're going to need a MRI for that, but you can see their points of attachment, the entire intercondylar fossa, and the intercondylar eminence, which is kind of shaped like a king's crown. Okay. For a home blad method, yes, the patient is going to get up on hands and knees, very much like they were crawling. Okay, and then you center to 1 inch superior to the femoral condyles. The patient's femur is basically got to get out of the way so you can see an open joint space. And the central ray is always for every, not just for the home blad, but for every, I think the Baclair is the exception. Almost every position here, the, dang it, what was I going to say? Oh, the central ray is perpendicular to the long axis of the tibia in every tunnel view. Okay. All right, so our home blad method promotes a little bit of elongation and foreshortening by the femur, but it does open the intercondylar fossa. Okay. Our Camp Coventry method is one of the more superior ways to capture the tunnel view. And again, the central ray, if you angle 40 degrees with a patient that is got 40 degrees of angle, then you're going to be doing just fine. Okay? Yeah, you need 40 degrees of angle, and it's got to go in. Yeah, right like that. Collimated field, you want to open up to 8 by 10 is sufficient for a tunnel view. The tunnel is the only area of interest. You've already probably gotten an AP. This is usually a tack-on exam. Okay. Yeah, perpendicular long axis of lower leg. And with the 3 major techniques, I'm sure there's plenty of minor techniques out there. A central point about this notion of perpendicular and Coventry, you're going to see, Camp Coventry, that's named after, it's a method, it's named after the 2 guys that invented the knee radiograph or invented this projection. There's a flexible amount of tube angle, depends on how much the patient can do. All right. Our ski jumper position is the tech's most favorite method for capturing a intercondylar fossa, and usually it's coupled with an upright bilateral knee study. Okay, so in order to pull off a ski jumper position, you do want to scoot the patient's feet back a little bit, so as they flex, the kneecaps are going forward into the board about 3-4 inches, so the patient can stand with a flexed knee. You're going to want to give them a sturdy hand grip, so that, especially if they're older, so that they don't fall over. Okay. Essential projections of the patella. A patella is basically a PA knee collimated down to like a 5 by 5. Okay. You don't see a lot of PA projections of the patella separate from a knee radiograph, but I think it's that they wanted me to teach you how to do a patella series separate from a knee series. So I'm going to go back and there have been a couple of years there that I didn't teach patella at all, but we're going back and teaching it now. So The Setagast method and also the Merchant's method and variations of those are how we open up the patellofemoral joint space, and typically the techs know that as a sunrise view. Okay. All right, so for a patella radiograph, notice we don't have the entire knee on here. It is a trimmed down view. You also, you're recommended to increase the KVP about 8 to 10 kVp from a regular knee. That increases the penetrability of the beam, and you get better penetration of the patella because the patella is usually superimposed over the distal femur. This radiograph here does show a fracture of the patella. That's a rare one. Usually you get a transverse fracture, but occasionally you get that's probably an avulsion. Okay. Center it to the patella, which is not the knee joint itself, so it's going to be tricky palpating this. And then secondly, if a patient has a fractured patella, they're not going to want to lay prone. So be mindful of that as you take a patella x-ray. We do a prone patellar x-ray to reduce edge blur and get, because the fracture is so difficult to see, as you can see in this radiograph, nice crisp edges with zero OID gives us better resolution of that fracture edge if it's there. So whereas if there's OID, because you're doing it AP rather than PA, a hairline fracture might be missed because it might be blurred out. Okay. Roll the patient's limb. Some people have offset patellas. They're not square to their knee. They favor to the medial side sometimes, and so the patient's knee might not be true AP, but the patella needs to be square to the radiograph or parallel with the image receptor roughly. Okay. So 5-degree lateral rotation of the heel, meaning 5 to 10 degree medial rotation of the knee. So centered to the mid-popliteal area, which is just, it's not hamstring and it's not calf. That's where you can find the popliteal area, not hamstring, not calf muscle. Okay. Collimated field, it says 6x6. You can probably go 5x5, 4x4, whatever. The point is you don't need the entire knee. You're just looking at the patella for this one. Okay. Lateral patella, very much like a lateral knee, flexion 5 to 10 degrees, because we're not going to flex 20 to 30 because the patella is injured, might be fractured. So you do want some flexion, but you don't want to aggravate the patient's injury. Okay. And with a transverse patella fracture, you're actually pulling the superior piece away from the inferior piece, because the inferior piece is still tethered to the tibial tuberosity, and the superior piece is tethered to the quadriceps muscle. And so a fractured patella transversely is going to separate the more you flex the knee. So flex it gently, only 5 to 10 degrees. You do not center to the knee joint space, you center to the patellofemoral joint space, which should line up. There should still be a skin divot showing you the edge of the patella, just center to the edge of the patella. Okay, and hopefully if you position correctly, the patella is oriented perpendicular to your image receptor like this. And you can see a nice open patellofemoral joint space. Does the knee joint space have to be open? No, that's a lateral knee radiograph. This is a lateral patella radiograph. All we got to see is the entire patella free of superimposition with an open patellofemoral joint space, if at all possible. You also want a decrease technique for this one so you can see more soft tissue, because it's also possible that they have not a patellar fracture, but they could have a subpatellar tendon rupture, which is also very common, especially in a hyperflexion situation, in a fall situation. You can have where the subpatellar tendon actually separates from the tibial tuberosity. So, okay, for a sunrise view, the standard view is called the Setagast method. Setagast method requires hyperflexion of the knee with a patient in a prone position until the patella is perpendicular to the image receptor, okay, in the table bucky. And then you shoot with an angled central ray such that the central ray passes through the patellofemoral joint space. So the central ray runs parallel with the edge or the skin divot that you can see at the edge of the patella. Okay, typically that angle is 15 to 20 degrees. So are you ever going to do a Setagast method? No, it's ridiculous. You have to lay the patient prone and hyperflex the knee. Okay, if the patient has a patellar injury, then this is exactly the way to exacerbate a patellar injury. And so you don't often do a Setagast method. Okay. Now, a reverse Setagast, that's more common. That's with supine and the patient's knee flexed and the foot flat down on the table. That's typically the one the technologists are doing. Okay, I'll show you the reverse Setagast when we go to lab. Okay. All right, so doing the sunrise method, central ray perpendicular to the joint space. No matter how you pull this off, I'm going to show you about 3 or 4 different ways to perform a sunrise view. Traditionally called the Setagast. There's also a merchant's projection. Central ray angle is required when space is not perpendicular to the IR. So just line up the central ray with the divot that you see, the edge of the patella, and the plane of that edge of the patella, and you'll be going through the patellofemoral joint space. Angle depends on the amount of knee flexion. Obviously, if the patient's injured, they might not be able to flex as much, and so that's going to affect the amount of angle you have to use. So it's very variable. Okay. For a collimated field, if you're going to do a bilateral, it says 4 by 10 inches. I'm going to say 4 by 14 inches probably. But for a single one, you can put a patella sunrise view on a 4 by 4 collimated field. You do not need the whole knee. They don't need to see the head of the fibula. They just need to see the patella and the patellofemoral joint space underneath it. Okay, here is your merchant's projection. It requires a 40-degree angle with the lower leg hanging off the edge of the table. Back in the day, they used to build a merchant's attachment to a radiographic exam table. Nowadays, we just do basically a reverse merchant's, but this contraption where the patient is tethered to a 45-degree sloping or a 40-degree sloping table surface, and then there's a cassette holder fashioned to their ankles, and then if the patient lays down, the x-ray tube is over top of their pelvis, angled down toward their feet. Again, the central ray directed through the patellofemoral joint space. Okay, a lot of people don't have the merchant's attachments anymore, and so a true merchant's projection is not often encountered. The closest thing we do to this is a wheelchair patella, where you put the cassette, you have the patient scoot out over the top of their wheelchair, and you put the cassette, you tuck their foot out of the way underneath the wheelchair, and then you put the cassette on the floor and you shoot straight down through the patella femoral joint space. Okay. And supine with one or both knees at the end of the radiographic table. Support the knees, lower legs with an adjustable IR holder device. So it implies that you have this IR holder device. Okay. It's very tricky to pull off at conventional merchants without the proper equipment. Okay. You do want the knees 40 degrees flexed and then central ray going through the patellofemoral joint space, okay, which again, it's variable according to how much the patient flexes. All right, so I tacked on femur projections, anatomy and projections, and we're doing real good. We're right at an hour, and we're right at 52 out of 64 slides. I can't believe that I was able to keep this so short comparatively for the number of slides we've covered. So let's get into the femur. Okay, so the femur, we've already covered the distal end included in the knee radiographs or the knee anatomy diagrams. So you need to know the proximal end of the femur. There's two bulges, lesser trochanters and greater trochanters, not tubercles, that's the shoulder. Okay. A femoral head and a femoral neck. There's a divot on the top of the femoral head called the fovea capitis. That is a ligament attachment that tethers the femoral head to the inside of the acetabulum, and it's also inside that ligament passageway is also the nutrient blood vessels for the femoral head come in through that ligament attachment that tethers to. It's called the fovea capitis. Is the divot point, and I'll show you that when we're going over the disarticulated anatomy from the bends. I'll show you the fovea capitis. Okay, femoral head, femoral greater and lesser trochanter. On the posterior aspect of the femur, there's actually a trochanteric ridge in between. It's a continuous, almost like a spine, between the lesser and greater trochanter. That's on the posterior side. On the anterior side, there's a theoretical line that connects the greater and lesser trochanter called the intertrochanteric line. The femoral neck is the number one site of fracture at this end of the femur, and the intertrochanteric line is the number two site of fracture at this end of the femur. Okay, both of those are considered hip fractures. All right. Your distal femur, the epicondyles at the distal end, those are medial and lateral condyles. The epicondyles, of course, are the bony prominences just above that. And we went over all of this just 30 slides ago. So it's the same as it was before. Intercondylar fossa, condyles, epicondyles, abductor tubercle, popliteal surface. Okay. The intercondylar fossa, again, is a depression in between the condyles of the femur. It's a hole. It's the tunnel in the tunnel view that we just covered. All right, to position and prepare your patient for a femur exam. Get rid of the pants, okay? Just get rid of the pants, all right? Don't try to, and for the femurs, I mean, you know, for the knees, people try to hike up the pant over the knee. No, just get rid of it. Get rid of the pant leg entirely. You'll create a wad of cloth that is a very distracting artifact. For femurs, good luck if you have them drop their trousers down to their ankles. Good luck doing the laterals, okay? It's just very difficult. Patient preparation, general patient position. Femur x-rays, yeah, you're going to be doing them laying down, okay? If they need their femur x-rayed, good chance it's broken, good chance they can't bear weight on it. So it's strictly stretcher transfer and shoot your pictures in the table bucky. Okay, 14 by 17 collimate in side to side, but use a 14 by 17 lengthwise, and you're probably going to do uppers and lowers, very much like you split an abdomen into uppers and lowers. You're going to split the femur into a proximal exposure and a distal exposure. Okay, now for the AP femur, you rotate the body part differently for the AP upper or the AP proximal femur than you do for the AP lower. So pay attention to that. That's a quiz question. SID is still 40 inches. ID markers are still important, and still the legal standard is they must be radiopaque. Radiation protection shielding is going to be tricky for your male patient, but if you have a small contact shield and you're not shy, you can pull it off. Or if your patient is well enough, you can hand the contact shield to them and tell them where they may place it. And then you can avoid all awkward, physical contact with their junk. Okay. Patient instructions, we are going to get some breath motion through the hip joint and in the pelvis. And so you do want, at least for the proximal femur, you do want a breath hold. Distal femur, not so much. It's whatever your preference. No one's going to scream at you if you have them hold their breath for the distal femur. Okay, it's not really necessary, but if you want to get into a good habit of consistent breathing instructions, and you're going to have them hold the breath for the proximal femur, it doesn't hurt anything to have them hold their breath for the distal femur either. It's unnecessary, but it doesn't hurt anything if you do it. Okay. All right. So what projections are we going to take of the femur? We're not doing obliques, okay? We're just not. We're doing APs and we're doing laterals, okay? Now, some people's laterals look like obliques because they don't know how to position, but that's not my problem. That's their problem, okay? Straw man. All right. So, collimated field. We do not need to see all the patient's adipose tissue, all right? Unless the femur is broken and it's compound, where it's like poking out of the skin, right? You're going to know if you need to open wider than the skin border. You're going to just know. There's going to be a lot of blood, okay? There's going to be a jagged chunk of bone that you won't be able to take your eyes off of, okay? The patient might be bleeding out, so you better move fast, okay? In that situation, forget your collimation. Slap and shoot. Open as wide as possible. Slap and shoot. That patient's got to get to surgery, and now. Compound femur fracture ain't no joke. All right. Otherwise, please at least collimate to the skin surface. You know that the femur is inside the patient's thigh. You know it. So collimate. The femur, the bone, is the structure of interest. Okay, unless you're doing a cellulitis study, but that's better visualized in ultrasound. All right. So here's our AP femur. Okay. Wow. Yeah. Typically, you don't get them all on one. Okay. If your patient's really short, they're like 5'2", okay, you might be able to capture the entire thing on one. I would check to make sure that the upper side of my light field is above the ASIS or at the ASIS, and the lower part of my light field is going through the tibial condyles at the very least. Okay? If either one of those is short, maybe, just maybe, consider doing an upper and a lower. Most of the time, the tech, if you're a student tech and you try to do a femur, you try to do it all on one, the tech is going to stop you and tell you to do uppers and lowers. Okay? Now, even doing my femur, the second shot can be typically reduced to a 10 by 12 field. So you'll get let's say you'll get a distal femur, including the knee and as much real estate as you can going superiorly, but you clipped a little bit of the hip. You're going to come back and get a 10 by 12 of the hip. You don't need another 14 by 17. You do need bony overlap, like you do with the abdomen. You need anatomy overlap between the upper and lower projection, okay? But I've x-rayed a lot of femurs, and I've never needed 14 by 17 for both projections. 14 by 17 for the big one, area of interest to the nearest joint, just like the rule for the tibia, and then a 10 by 12 for whatever I missed, whatever wasn't included in the first radiograph. Okay. All right, leg extended. If we're doing an AP femur and it is the distal femur, we want to make sure the epicondyles are parallel to the IR, very much like a knee. Okay, and so we rotate, and remember, rotating a leg, we rotate at the thigh and at the calf at the same time, just in case there's an injury. If it's trauma, we don't rotate at all. We shoot it as it lies. Okay, it's going to be oblique, but there might be a shaft fracture of the femur. Okay, and so rotation would exacerbate the injury, and there's a big old femoral artery running up through there. You really don't want to lance that. You really don't want to slice into the side of that femoral artery. That is a bad time for the patient. That is a really bad time. It's a bad 2 minutes, and that's all the patient gets. Yeah, if you notice that the femoral artery is bleeding, hold pressure on that and don't let go. You're keeping the patient alive because they can bleed out in 2 minutes. All right, next. See, I told you the body part rotation was different. So remember, the previous slide, I said epicondyles parallel to the image receptor. We're actually doing a 10 to 15 degree internal rotation of the femur for the proximal end of the femur because we want that greater trochanter to be in profile on the lateral side of the hip. Okay? In order to do that, we have to turn the toes in about 15 degrees. Okay? That gets the trochanters and the trochanteric crest off of the femoral neck, and so we can see the femoral neck without superimposition with this 10 to 15 degree internal rotation. So just remember that the positioning for the proximal and distal femur is very, very different. That's going to be a quiz question. For a lateral femur, we want to do like this: unaffected leg extended forward, knee slightly bent, and affected leg side down. We want to do a medial lateral with the patient laying on their affected side. Unless it's trauma, we're going to do a cross table if it's trauma. Okay? So if it's non-trauma, you can flex the knee 45 degrees, open the collimated field to the buttocks on the proximal end, and to include all of the femoral epicondyles on the distal end and the femoral condyles. Okay, when we do a proximal lateral, it's very much like a frog leg. Okay, they have the unaffected leg backwards, and kind of really what you want to do is have the patient roll their leg more out to the, so you don't want to tip the pelvis this much. I've never seen it done like this. You want to do more like a frog leg, where the pelvis is more at a 45 degree oblique and the leg is frogged out to the side. That's a better lateral than whatever this is. Okay, but this is the one in the book, so if I quiz you on lateral femur, it'll be based off this. So 15 degrees, 10 to 15 degrees of rotation from a true pelvis. Both the central rays enter roughly the mid-shaft. Typically the guidance is include the femoral epicondyles, include collimation all the way up to the ASIS for the proximal end, and then just grab as much, open the field and extend and get as much of the femur as you can when you're doing uppers and lowers. Okay, I'll see you guys in lab next week for this one. That is all we had to cover. I can't believe I got this 64 slides done in just an hour and 14 minutes. That was crazy. Whew. Okay. Sorry, I did trip over my words a little bit in the middle. I got a little bit lightheaded there, but I think I'm okay. Thanks. You guys have a good night.